Hi, everyone. I'm Megha Garibaldi, Chief Growth Officer at The Atlantic. I'm joined by two experts in their field to talk to us about the rapidly changing world of science with respect to Alzheimer's disease. And we're talking about from detection to diagnosis to treatment. Welcome back, Dr. Brandy Matthews. And we also have Ian Creamer with us, the Executive Director of the LEAD Coalition. We just saw an incredible documentary, Reaching for the Sun, and I think it does a great job in illustrating the hope we now have around Alzheimer's disease. It also sort of highlights the sort of different nuances around the different stages of the disease. Brandy, what can you say about the different stages of this particular disease to help us understand it better?
Yeah, thank you for the question. So I think it was alluded to in the documentary that this disease is defined by its pathology. So some abnormal proteins accumulating in the brain, and that's really the initiation of the disease up to 20 years before symptoms might emerge. But even in the context of symptoms, there's a continuum. And some patients may present with very subtle symptoms that aren't necessarily interfering in a significant way in their day-to-day, and we call this mild cognitive impairment. And you may advance beyond that stage of symptoms to a dementia stage, where changes in cognition or thinking can interfere with your day-to-day activities. We refer to this as dementia, and the dementia can come in a mild, moderate, or severe variety. I think a challenge for us now at this current moment in time is that the mental image that people maintain of Alzheimer's disease is the severe stage of dementia. But we've entered a period of time where we can initiate new therapies in earlier symptomatic stages of disease, when people are only experiencing mild cognitive impairment or the mild dementia stage. So we need to have a real frame shift in how we're thinking about Alzheimer's disease as defined by its pathology and on a continuum of symptoms.
And I would just add that particularly in these early symptomatic stages, quality of life can and should be enormously high. And that comes down, the question of whether it is or not comes down to whether people know what they're facing and know what they're not facing. They get a timely and accurate diagnosis, and they get the right kinds of both clinical and non-clinical supports. So to your point about the stigma of assuming everyone that has Alzheimer's disease has this sort of end-stage severe impairment, we have to break down that stereotype and remind people that at particularly these early symptomatic stages, people are, I wouldn't say normal, but they're very close to who they have always been, and the changes tend to be more subtle. And the first step for many people in arriving at a diagnosis is recognizing in themselves, or their physician or loved ones recognizing in them, change over time. If you've always been bad at remembering names and you're bad at it at 75, it does not mean you have Alzheimer's disease. It means you've always been bad at remembering names. But if you've always been great at remembering names and you're starting to struggle with that, or other routine activities, balancing a checkbook, driving, finding your way, holding a full conversation, remembering the last paragraph that you read in a news article or the last scene in a movie, those are subtle signs that ought to be discussed with your physician.
So we're talking about the early stages. Can you go a little deeper into what care options look like and how folks can sort of have the ability to carry on with their lives?
So as I mentioned, we've entered this new period of time where we have the potential therapies that were discussed in the documentary. There's an opportunity to intervene at those earliest symptomatic stages that we didn't necessarily have in the past. I think Dr. Sabah in the documentary speaks to symptomatic therapies that aren't even necessarily indicated for those earliest stages of symptomatic disease. So we have this window of opportunity to intervene, and consistency across studies that demonstrates that the earlier we intervene in that symptomatic stage of disease, the more impact you can potentially have for patients to maintain those activities that Ian mentioned.
And, again, at that earlier symptomatic stage, because quality of life can be high with the right supports, both clinical and non-clinical, I wouldn't necessarily say people require most people, require a great deal of what many of us think of as care. Someone taking over aspects of their lives, but they need support. We all need support throughout our lives. Maybe you need a little more in these early symptomatic stages. And if you can have more time when that time is most valuable in these milder symptomatic stages, then you can have more self-determination, more control over your own quality of life, more independence, more time to enjoy the things that are most important to you and your loved ones. And these new disease-modifying therapies have the opportunity for people to have additional time at that most beneficial stage of disease progression.
So it sounds like we are now at a stage where these advances have been made, and that's great. It's positive. But it's also incumbent upon actually looking out for some of these signs and these symptoms for yourself, for the people around you. How can you think about the differences between memory and thinking issues that happen organically through the process of aging versus it actually being a sign or a symptom of the disease?
Yeah, it can be challenging, actually, because the manifestation of changes in memory and thinking that might be associated with an underlying pathology like Alzheimer's disease have a lot of individual variability. But there are a few rules of thumb or heuristics. If you're repeatedly experiencing the same challenge, so as Ian mentioned, repeatedly forgetting names, forgetting what you had for breakfast, or if you're having challenges that are suddenly beginning to interfere with your day-to-day activities, this is certainly something that needs to be further evaluated, as it likely indicates this is not the kinds of changes we might expect to see with normal aging.
And the other thing I would add to that is that, at least in this culture, we are not used to talking about brain health. We talk about a lot of other aspects of our health with friends, with family, with loved ones, with our physicians. And there is a lot of stigma around this misperception that all Alzheimer's is end-stage Alzheimer's. And understandably, there's a lot of fear of that. But we are talking about something fundamentally different in these early symptomatic stages. And we need to change our own willingness to voice those concerns that we may be having, in part to find out if we have Alzheimer's, but also to find out if we have something that isn't Alzheimer's that is also treatable, just happens to be different, that you wouldn't take an Alzheimer's medication for if that's not your disease. But it's also important to know if you do have this disease, because now there are disease-modifying treatments available. And as Dr. Matthews said, they are most effective when started as early as possible in the course of the disease. So we need all of us to be more willing to raise even small concerns, things that may seem small to us, raise them with our doctors and say, is this normal? Is this okay? Or do we need to dig a little deeper? We also need our physicians to lean in and normalize conversations with us about brain health. And I think we're all getting more used to, just at every checkup, our doc asks us, are you worried about things more than you usually are? Are you feeling a little depressed? No? Good, we're moving on. And they ask that about a variety of conditions. What they don't ask us routinely is, how's your thinking? Any concerns recently? And if the answer is yes, they can dig a little deeper. Maybe it's Alzheimer's, maybe it's not Alzheimer's, but it's an opportunity, if the doctor leans in and asks first, for us to feel more comfortable. And if we've been asked that question for 10 and 20 years straight, we shouldn't wait till we're 75 to be asked that question. If we get asked that question in pediatric visits, young adult visits, midlife visits, then if and when there's something of concern to us, we're used to hearing that question. We're going to be more comfortable saying, actually, I've been having some concerns I'd like to discuss with you. Let's dig into this together.
Ian, if I could just add to that, the Alzheimer's Association conducted a study and found that about 97% of primary care clinicians won't volunteer this question to their patients, that they're waiting for the patients or a loved one to bring it up. So I share that with you just to empower you to ask the question, is there something we should do to assess my memory, or to take advantage of your annual wellness visit to raise the issue of how's my brain health?
Yeah, I mean, that's fascinating, right? Because it's a small tweak almost and can be rolled out at a mass scale. So that's really fascinating. Let's dive into diagnoses. This might be a fairly straightforward question with a straightforward answer, but why is it so critical for early diagnoses, early detection and early diagnoses? Can you talk to us a little bit more about that?
Yeah, so I think part of it is obvious that the earlier you have a diagnosis, the earlier you could make an intervention. But the challenge has been there's been a paradigm shift from making a diagnosis that's based on clinical symptoms or just memory and thinking changes to making a diagnosis that can be confirmed with a test for the pathology of Alzheimer's disease. So we have tools available, PET scans that can take pictures of the abnormal proteins in the brain of people who have Alzheimer's disease, cerebrospinal fluid tests that are obtained through a lumbar puncture, and emerging blood-based biomarkers as well that can reinforce that this pathological disease is the cause of the symptoms and help the clinician gain confidence in providing the diagnosis. So I think that clearly we have new interventions that are possible if there is a timely and accurate diagnosis, but we also have new tools that are accessible to confirm the diagnosis of the underlying pathology.
And it's really important that the right tools be used at the right time by well-trained physicians. So if it's a PET scan, if it's cerebrospinal fluid, if it's these new blood-based biomarkers, where I think a lot of the field is moving very quickly, and we're all used to having blood samples taken at a fairly routine level, check for cholesterol, PSP tests for men, other things. If we can routinize that and increase both physicians' comfort ordering those tests and understanding how to interpret them, but also patients' willingness to undergo these tests, we all get factual information on which we can make both, again, medical and non-medical decisions. Look, living in the dark, living in uncertainty is not a strategy, and it's not a solution to improve our health. Information really is power, and I'll try to come up with more trite expressions to use, but just that's the take-home message. Knowledge is power. The caveat for that is the information has to be accurate, and it has to be delivered in a compassionate and actionable way. So, look, we've all gotten bad news in our lives about various things. Getting a diagnosis of Alzheimer's is not good news. But if it's true, and it's delivered in a way where you are empowered, you're told, we've caught it early, there's plenty we can do, you have options, you have choices, your quality of life is high now, and we can preserve that for as long as possible if we get you onto the right therapies. Well, what a blessing that is, both to the clinician who can do a better job fulfilling their Hippocratic oath, not only of do no harm, but also provide care, but a blessing to the individual who receives that diagnosis, knows the truth about what they're facing, can be empowered at the earliest stage of disease to be involved in every aspect of decision-making for themselves. Maintain their agency, not have someone have to step in and make decisions for them, but it's self-determination. Truth and knowledge are power. We can now own that power with these better tests and better treatments being available.
Well, in the spirit of information is power, can you just talk a little bit more? I know you alluded to some of the methods currently in play. Can you just talk to us about the current methods of diagnoses that are available?
Sure. So I think in the symptomatic stages, it begins with a cognitive assessment. So checking memory and thinking and assessing that. But then again, moving on to understand what is the pathology in the brain that's causing those changes in memory and thinking. And I mentioned a few of those tests. One, a PET scan, an amyloid PET scan that can take a picture of one of the abnormal proteins that accumulates in the brains of people who are living with disease. So this is a real advance and step forward to be able to make this diagnosis during life. And other biomarkers that are highly concordant with PET scans, emerging blood-based biomarkers, which would introduce some cost and time efficiency, and also cerebrospinal fluid, which is indicative of some stages of amyloid accumulation, either before or after. They may show up on a PET scan. So these tools are available in the clinical setting and used in varying degrees by specialists and increasingly by non-specialists. So we're working very diligently to democratize access to these types of tools.
And one of the real keys is that these need to be validated tests. I know that seems like a bit of, forgive the expression, a no-brainer. But there are a lot of physicians that just use the eye test. They size up their patient in a very high-pressure, short clinical visit where they have a lot to do, and they think to themselves, they seem okay? That's not real medicine. Real medicine is using validated tools and instruments, whether those are very high-tech like PET imaging or CSF or these new and emerging blood biomarkers, or whether they're sort of old-fashioned neuropsychological tests. Some of you may have heard of the clock drawing test, where the doc may ask you or the nurse may ask you, just draw a clock face and put the hands into 2 o'clock or 7:30, and that gives them an indication. But there are unfortunately a number of physicians, thankfully not as many as there used to be, who just use the eye test and a thumbs up, thumbs down as to whether they're going to pursue it. And we need them to use the validated tests. And just to get a little DC policy wonky for a moment, one piece of legislation for all of you to be aware of, for those of you that might be members of Congress or talk to members of Congress, there's a piece of legislation called the Change Act. And don't worry about the acronym. If you talk to a member of Congress and say, the Change Act is important, it ought to pass this year, all that does is require that in the free Medicare annual wellness visit that every Medicare beneficiary is entitled to every year, annual, you have a right to a free cognitive assessment. And the Change Act just says, when doing the cognitive assessment, you ought to use a validated rather than an unvalidated tool. No more guesswork, let's use science. Science, evidence, treatment based on that.
We're talking a lot about what is happening in terms of the advancement in technology and the breakthroughs, but it also has to do with changing the perception around the disease. Can you talk a little bit about the role of this shift and how that would impact furthering Alzheimer's innovation?
Sure. So I think, as we have mentioned, there is a perception that Alzheimer's disease is equal to the severe stage of dementia. And what we need to do is have a more transparent dialogue that, like other disease states, this exists on a continuum. It's due to pathology. It's not intentional or because someone's not trying to remember, so that there's an open conversation, not only with clinicians, but one thing that we haven't really mentioned is to have an open discussion across family and friends, so that there's an increasing awareness that this is something that we need to be discussing because we can make an intervention, because we can make a difference. Historically, I think there was some nihilism that there wasn't anything to be done, so we ought not talk about it. And I think as Ian mentioned, on the clinician side of the equation, there has been a perception of great stigma for patients, and they felt as though this might be harmful to discuss or to diagnose. And I think that we've definitely reached a point where we need to acknowledge that this is not the current paradigm for caring for patients, and that we all need to be individual advocates for our own brain health. And hopefully then we can meet in the middle with the healthcare professionals who also have this new and evolved understanding.
And I'll just give you two strategies for helping overcome stigma, and they both go to Dr. Matthews' point about being a self-advocate or advocate for those that we know and care about who have faced these diseases. I'm an introvert. I know I'm up on stage. I'm an introvert, so not super comfortable having to be on stage and holding a microphone. But watch me in a grocery store line. And my job in a grocery store line is not only to wait to move forward and check out with my groceries, it's also to engage strangers and tell my family's story about dealing with these diseases and normalize the conversation. And when I first started doing this close to 30 years ago, I was terrified. Again, introvert, but also it's kind of weird to just turn to a stranger and say, hey, I've had lots of Alzheimer's in my family. How about you? And it's weird, but you'll be surprised with the results, because when you tell your story, and it could be about Alzheimer's, it could be about having a Cub Scout for a grandchild, people open up and they feel more comfortable sharing their story. And what I find, maybe what you'll find, is one of two things. They'll tell you their stories about Alzheimer's, and they're not all going to be about death and despair. They're going to be about, hopefully, about quality of life that their loved one enjoyed because the family was open and loving, and neighbors and friends and fellow parishioners and coworkers and others were open and loving. The other thing they might tell you is, our family's been spared. There but for the grace of God go I. And they are so grateful their family hasn't had to face this, and they want to know what they can do to make the world a better place for people who are facing it. So normalize that conversation in a clinical context, normalize it at the grocery store, normalize it in the workplace. The more we are open about talking about our brain health, the easier it is to talk about changes in our brain health. The second thing, my dad got very comfortable talking about his cognitive impairment. He didn't happen to have the Alzheimer's form. He had three other diseases. His scores on amyloid were kind of borderline, so he may or may not have had Alzheimer's disease, but he definitely had three other things that were causing cognitive impairment. He didn't like the D word. I think some of you know what D word I'm talking about. For those who don't, dementia. He didn't like that word. But he would talk very openly, name the diseases he had, discuss very openly the symptoms he was experiencing, what he maintained in terms of quality of life and abilities, and where he was struggling. And that was very empowering. And I'll stop with this point. The weirdest reaction my dad ever got was one I hear a lot from people who are living with any stage of the D word, or sometimes mild cognitive impairment. Sometimes the reaction is, funny, you don't look like you have. These are in that big suite of diseases we call invisible diseases. Sure, you don't look like you have because you are functioning at a quite high level, particularly if you have the benefit of disease-modifying therapies, again, for Alzheimer's or other conditions, that empower you to live as full and rich and as close to normal a life as you've enjoyed previously. So let's attack these diseases with truth, with treatment, and with telling our stories.
Well, on that note, truth, treatment, a lot of hope. Thank you so much, Brandy and Ian, and thank you to all of you for joining us today.